بسم الله الرحمن الرحيم ربي اشرح لي صدري ويسر لي أمري واحلل عقدة من لساني يفقه قولي. Assalamu alaikum everybody. This is the second part of drug treatment of mania and manic depression, where we are going to talk about the pharmacology of lithium and the use of atypical antipsychotics in treatment of mania and manic depression. So what are the main goals of this presentation? The first, we are going to know what are the pharmacokinetics of lithium, including absorption, distribution, and elimination. Then we are going to talk about the mechanisms of action of lithium in treatment of mania. Also, we will discuss the side effects and the acute toxicity of lithium. And finally, we'll talk about the use of atypical antipsychotics in treatment of mania. So, what is the pharmacology of lithium? I consider lithium as a wonder element because it resembles sodium, being a monovalent cation, but it has a many important biological activity, as we will see in a few minutes. So usually lithium is given as a salt, as lithium carbonate or lithium citrate. The pharmacokinetic of lithium resembles sodium in being completely absorbed after oral administration because it is normal monovalent cation, and also it produces peak plasma concentration within 1 hour if it is in the form of immediate release, or it can produce a peak serum or plasma levels of 4 hours if it is in the form of extended release. After it is absorbed, as we know, it is a monovalent cation, therefore it has no significant protein binding, it doesn't bind to plasma protein, and we expect, being a hydrophilic, to have a volume distribution equals total body water of about 40 liters, which is equivalent to 0.6 to 0.9 liter per kilogram. Of course, being a hydrophilic, we expect it has a slow through the blood-brain barrier, therefore it will take some time before it reaches therapeutic levels in the brain. After distribution comes the elimination, and being a monovalent cation, we expect that it's not metabolized. It will be excreted unchanged through the kidney, and therefore we'll expect that its half-life time, which normally ranges between 18 to 36 hours, will be longer in people who are suffering from kidney problems or old age. So this is the pharmacokinetic of lithium. And the most important, we should always remember that the elimination of lithium is kidney dependent, and therefore its elimination will be affected by any impairment in the renal function or in old age, as we will see later. So how lithium produces its action? They have said that lithium produces antimanic effect through two mechanisms. There are other mechanisms, but I'm going to speak about two important mechanisms. First is by the inhibition of inositol monophosphatase. This is the first. The second, by inhibition of glycogen synthase kinase 3. So what does it do to the inositol monophosphatase enzyme? As we know, in receptors which are linked to G protein, usually when they are stimulated, they will activate G protein, and this G protein in turn will activate a membrane enzyme. In this case, it is phospholipase C. Phospholipase C will convert phosphatidylinositol diphosphate, which is the phospholipid, membrane phospholipid, phosphatidylinositol diphosphate. It will convert it into 2 second messengers, the IP3 and DAG. As we know, IP3 or inositol triphosphate will leak into the cytoplasm, and it will lead to release of calcium from its storage sites and increase in intracellular calcium, and this will end up with different cellular effect. DAG, on the diacylglycerol or DAG, on the other hand, it will activate different kinases in the cell. So this is the 2 second messenger. The IP3 inositol triphosphate, after it produces its action is terminated by inositol monophosphatase. Inositol monophosphatase. This inositol monophosphatase will release the inositol from the complex, producing free inositol. The free inositol will enter into the synthesis of phosphatidylinositol diphosphate. Therefore, IP3, once it ends its physiological function, its physiological termination is done through the inositol monophosphatase, which will free inositol, and the free inositol is used again in the synthesis of the membrane phospholipid phosphatidylinositol diphosphate. Okay? Now, so what will happen in this case? If I inhibit inositol monophosphate, if I inhibit it, what will happen? معناها there is no free inositol. معناها there is no phosphatidylinositol diphosphate, i.e. depletion of phosphatidylinositol diphosphate. When this is depleted, that means there is no IP3 and there is no DAG formation. Okay? So this is very simply how lithium produces its action. It decreases the availability of inositol by inhibiting inositol monophosphatase, and this will end up with decrease in the synthesis of IP3 and DAG. Of course, this, if it happens with excitatory neurotransmitters, as we talked about in the last lecture, like glutamate and dopamine, this will result in a decrease in glutaminergic activity. That means a decrease in excitatory neurotransmitters in the brain. In this case, يحصل restore of neurotransmitter balance, يعني restoring the balance between excitatory and inhibitory neurotransmitters. Okay? يبدأ this is very simply how the first mechanism proposed for lithium, which is really a very interesting mechanism, and it shows how this very simple cation can produce changes of second messenger activity. Okay? يبدأ this is the first mechanism. The second mechanism is through the inhibition of glycogen synthase kinase 3. Glycogen synthase kinase 3. This glycogen synthase kinase 3, which is known as GSK3, glycogen synthase kinase 3. This is a multifunctional enzyme. It has many functions, many biological functions. The first, it is involved in glycogen metabolism. Glycogen metabolism. How does that? By inhibiting glycogen synthase. Glycogen synthase. We know that glycogen synthase is the enzyme responsible for conversion of glucose to glycogen. يعني storage form of glucose. يبقى glycogen synthase function is to convert glucose into glycogen. This glycogen synthase is inhibited by the GSK3 enzyme. The GSK3 enzyme will inhibit glycogen synthase. That means it will inhibit conversion of glucose to glycogen. This is first. Second, GSK3, it has another very important effect in the cell signaling mechanisms. Especially with the cell growth, cell differentiation, and cell survival, especially in the cell division, in cell growth, and cell survival. Okay, this of course it is a new line of research where GSK3 they think that it is involved in the apoptosis, which is the programmed cell death. Also, GSK is involved in gene expression, where they think that expression of genes where any defect in this activity will result in abnormal proteins. These abnormal proteins are involved in many brain damage, including Alzheimer's and mania. يبدأ lithium, it will inhibit glycogen synthase kinase enzyme. With glycogen synthase kinase, I might provide a separate talk about this enzyme because it is a very important enzyme and it is involved in the new development of drugs, especially for treatment of diabetes and in Alzheimer's disease, as we will see later. So by inhibition of this glycogen synthase kinase enzyme, which has the multifunctions, by inhibiting glycogen synthase and by affecting SYN signaling and also in the gene expression of abnormal proteins. So what will happen with these enzymes? So it has been proposed that overactivity of GSK is associated with manic symptoms like elevated mood. Elevated mood, we have said, is due to disbalance between excitatory and inhibitory neurotransmitters. Also in impulsivity and high energy because there is inhibition of glycogen synthase and insomnia. They said that lithium, by inhibiting this enzyme, it produces antimanic effect by stabilizing the mood, especially in bipolar illness. Therefore, these are the two mechanisms which are responsible for the antimanic effect of lithium. First, by inhibiting inositol monophosphatase enzyme, therefore decreasing the availability of the 2-second messengers, IP3 and DAG, and this will result in a decrease in excitatory neurotransmitter activity, restoring the normal balance of activity between excitatory and inhibitory neurotransmitters. Second, by inhibition of glycogen synthase, and therefore they will inhibit the elevation of mood, impulsivity, high energy, and insomnia, which are the main features of mania. Lithium, although it is a monovalent cation, it produces several side effects, including most organs in the body, and therefore it should be monitored very closely, as you will see in a few seconds. So why we should monitor lithium blood level? When the lithium is given, usually we should measure the blood level of lithium to make sure that it is in the safe range. So the reasons why we should monitor lithium blood level when the patient is given lithium, we should monitor blood levels. Why? First, because lithium, it has a narrow therapeutic index. When narrow therapeutic index, as we have said before, the difference between the therapeutic blood level and the toxic blood level is very small. يعني any increase in the dose of lithium will produce high toxicity. So usually the therapeutic range is between 0.6 to 1.2 milliequivalent per liter, and the toxicity starts to appear if these levels goes up to 1.5 milliequivalent. As you can see, there is no large difference between the two. Okay. Second reason for the monitoring of lithium blood level is the individual variability. يعني the patient's variability will affect the rate of excretion or elimination of lithium. The most important variability individual is the renal function. As we have said, in the lithium depends completely on renal function. Lithium elimination from the body depends completely on the renal function. If the renal function is affected, in this case, the elimination will be affected, and we might enter into the toxic levels of lithium. The second is the hydration status, because if the patient is well hydrated, he will eliminate lithium more fastly. But if the patient is not hydrated, معناها he is dehydrated, in this case, what will happen? بيحصل more reabsorption of lithium in a larger amount, and it will exceed toxic levels. A third is drug-drug interaction. Many drugs like non-steroidal anti-inflammatory drugs and the AC inhibitors, they affect the glomerular filtration rate, and therefore they will inhibit the lithium elimination. For non-steroidal anti-inflammatory drugs, they are known to inhibit prostaglandin synthesis. They inhibit the prostaglandin synthesis. And we know that prostaglandin, they are involved in glomerular filtration rate. Prostaglandins, they involved in glomerular filtration rate. Therefore, by inhibiting prostaglandin synthesis, we inhibit glomerular filtration rate, and this in turn will inhibit elimination of lithium, i.e. increasing levels of lithium, especially when there is dehydration or when it is used chronically. When non-steroidal anti-inflammatory drugs are used chronically with lithium. Also, ACE inhibitors, اللي هم antihypertensive drugs, and they inhibit aldosterone, the hormone, which is responsible for the reabsorption of sodium. That means by inhibiting aldosterone, they will decrease sodium levels in the blood, and decreasing the sodium level will result in increased lithium reabsorption. Increase in lithium reabsorptions will increase toxicity. Yet this is the third reason for the individual variability. Last is age. As we know, by aging, renal function will be affected. As the person increases in age, his renal function will be decreased. This is why we monitor lithium blood levels, because of the individual variation related to renal function, hydration status of the person, drug interactions, and age. Lastly, lithium is not metabolized in the body. It is only eliminated by excretion. Therefore, any impairment in the renal function will result in rapid accumulation of lithium in the body. The thing with monitoring lithium blood levels, that lithium produce delayed onset of toxicity. Delayed onset of toxicity. What does it mean? Accumulation will start gradually till the point it produces toxic levels which is not noticed by the patient or by the physician. Lithium is most dangerous, produces delayed onset of toxicity. The symptoms may lag behind the serum levels, especially in chronic toxicity. Therefore, we have to monitor lithium blood levels regularly. This is done, as you will see later, at the beginning every week, and then later every 3 months. So why we monitor lithium blood level? Because lithium, it has many side effects on different organs of the body. It has a serious side effects as we will see in a few seconds. And first, on the central nervous system, lithium can produce tremor. Lithium can produce tremor. With tremor produced by lithium, usually it takes place in 25 to 60% of patients. طبعا التريمور differs in severity. The exact mechanism is not known, ولكن they think that it is due to the disbalance between dopamine, 5-hydroxytryptamine, and noradrenaline. We know that dopamine is involved in the regulation of muscle tone, and therefore any disturbance in dopamine neurotransmitter will result in different muscle tone, and this will result in tremor. Tremor severity differs. Usually there is what is known as therapeutic tremor. Therapeutic tremor usually it is mild or fine, is not coarse, it is fine tremor, and it is usually localized to the hands only. This is known as a therapeutic tremor. If it appears, it indicates that lithium is in the therapeutic range. Okay? This is first. Severity, when it is mild, fine tremor, localized only to the hand, that means we are achieving a therapeutic blood concentration of blood concentration of lithium. Okay? The other type of tremor is known as toxic tremor. Toxic tremor. For toxic tremor, usually the tremor is not fine as it is in the therapeutic tremor. It is coarse tremor. Coarse tremor. Plus, the tremor is irregular and spreads to other limbs so it is coarse, irregular, and spreads to involve other limbs. Also, there are other signs of toxicity. When we see toxic tremor, we see other signs of toxicity, like ataxia, like vomiting, like ataxia. And the person is ataxic, is not moving in coordination. Like vomiting, the patient is vomiting, and like confusion. Usually toxic tremor is accompanied by ataxia, vomiting, and confusion. This is the first side effect on the central nervous system. It produces tremor. A tremor can be therapeutic tremor, where the tremor is mild, fine, and localized to the hands. And it can be a toxic tremor. For toxic tremor, usually it is coarse, irregular, and spread to other limbs. And usually it is accompanied by other signs of toxicity, including ataxia, vomiting, and confusion. This is the first side effects of lithium. The second side effects of lithium is cognitive slowing. The cognitive slowing. Cognitive means learning, mental activity, processing speed will be decreased. Mental processing speed will be decreased. This will include all mental activity, including attention. Attention of the person is not, he cannot concentrate on any mental activity. There is a loss of memory, especially working memory, which is needed in doing jobs. وكذلك في الverbal fluency. For all these side effects are indication of toxicity. The patient becomes mentally sluggish, slower in solving problems, or retrieving words. They said that this cognitive slowing is due to inhibition of the GSK3 enzyme, اللي هو glycogen synthase kinase 3 enzyme. By inhibition of this enzyme, this will affect synaptic plasticity, which is the ability of neurons to communicate, and this will result in decrease in mental processing speed, resulting in lower attention, loss of working memory, and verbal fluency. This is, of course, usually seen in high toxic range of lithium blood levels. Also, lithium can produce ataxia and confusion. This is only seen with toxicity when there is a high blood levels of lithium in the blood. طبعا ataxia or confusion is related to the mental function. Lastly, lithium can produce seizures, اللي هو convulsions, especially in high toxic doses. This طبعا convulsion is due to severe disturbances in the neuronal functions, especially neuronal ion channels. These are the central nervous system side effects of lithium. It produces tremor, which can be fine, which is a therapeutic tremor, or it can be coarse, which is the toxic tremor. It can affect the cognitive function of the body, producing slower mental processing, especially attention, working memory, and verbal fluency. It can produce ataxia and confusion in high toxic doses, as well as seizures. The second important side effect we should always consider is the renal system, the side effects in the renal system. One of the most important side effects of lithium on the renal system, they produce what's known as nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. Nephrogenic diabetes insipidus. What is nephrogenic diabetes insipidus? Is the loss or effect of antidiuretic hormone on the nephrons of the kidney. As we know, antidiuretic hormone is a hormone secreted by the pituitary gland. It will act on the nephron and it will increase the absorption of sodium and water. This effect is lost and therefore antidiuretic hormone is not functioning. This will result in polyuria and polydipsia. This is second side effects on the kidney of lithium. It can produce chronic tubulointerstitial nephropathy. Chronic tubulointerstitial nephropathy, which is takes place after chronic lithium exposure, not after acute, after chronic. If the patient is treated with lithium for a long period of time, chronically, this might result in chronic tubulointerstitial nephropathy. Usually, this is caused by the deposition of lithium in the nephron, and this will produce damage of the renal tubules. طبعا this is very dangerous. Why? Because it is unreversible. It is unreversible. You cannot reverse it. Unreversible means you cannot reverse it by stopping the administration of lithium. That's why monitoring renal function is mandatory. Monitoring renal function after chronic therapy with lithium is mandatory. معناها it is a must. It is a must. After a patient is treated for a long period of time with lithium, we should measure renal function regularly. Okay? Yep, this is the second renal side effects. Third renal side effects is the reduction in the glomerular filtration rate. Reduction in the glomerular filtration rate. طبعا reduction في glomerular filtration rate will result in an alter in electrolyte balance, especially of sodium and potassium. Well, this is as well is very important physiological action. Okay. Yep, these are the side effects of lithium on the renal system. It can produce nephrogenic diabetes insipidus, and this can result in polyuria and polydipsia. Also, it can produce chronic tubulointerstitial nephropathy, especially after chronic use, and this is very dangerous and it is irreversible and can lead to kidney damage. Also, it can reduce glomerular filtration rate, and this is very important in the balance between sodium and potassium. Third system affected by lithium is the endocrine system, especially the thyroid gland and the parathyroid gland. First, it produces hypothyroidism. Hypothyroidism. Well, hypothyroidism means decrease in both hormones, thyroxine and triiodothyronine, T4 and T3. Decrease in these two hormones, of course, will result in hypothyroidism. And hypothyroidism symptoms includes low energy, the patient will feel fatigue. لأن, as we know, the thyroxine is involved in production of energy. In this case, if there is no thyroid hormones, will result in low energy, like in fatigue, like in cold intolerance. He cannot tolerate cold intolerance, and as well bradycardia, slow of heart rate. It can produce goiter, and as we know, if the pituitary gland senses lower levels of thyroxine, triiodothyronine, it will stimulate thyroid stimulating hormone. With thyroid stimulating hormone will increase the size of the thyroid gland producing goiter. Other side effects including weight gain. All these, if it happens to the patient treated with lithium, it indicates hypothyroidism. Okay. Hypothyroidism usually takes place in 20 to 30% of patients treated chronically for longer than 2 years. We are not expecting hypothyroidism to take place within a week or two, لكن it takes place after treatment of patient with lithium for a long period, longer than. That's why we should consider these side effects after chronic therapy with lithium. The second side effects of lithium on the endocrine system is the hyperparathyroidism and hypercalcemia. As we know that the parathyroid gland senses any decrease in calcium level in the blood. When calcium level in the blood is decreased, the parathyroid gland will move calcium from bone to blood. As we know that bone is the main store of calcium, it moves calcium from bone to blood, and also it will increase calcium reabsorption from the kidney. If we give lithium for a long period of time, it will decrease the calcium receptor sensitivity in the parathyroid gland. Decrease the calcium on the parathyroid gland. There are certain receptors which are sensitive to the calcium. This sensitivity is inhibited if lithium is given for a long period of time. So what will happen? The parathyroid gland will sense there is no calcium in the blood, so it will move calcium from the bone to the blood, increasing the mobilization of calcium from bone to blood, and this will result in hypercalcemia. So in this case, what will happen? What we will see? This mobilization of calcium from bone to blood will produce different side effects or different symptoms. It will produce different symptoms on the muscle itself and on the mental activity. On the mental activity, there will be a confusion, depression, and mood changes. On the muscle itself, skeletal muscle, the person will feel fatigue with pain in bone. Also, because of the higher calcium, which is filtered through the kidney, this will result in kidney stone, and it will produce polyuria and polydipsia. Therefore, lithium, if it is given for a long period of time, what will happen? The calcium sensory receptors which are present on the parathyroid gland will be decreased, and this will result in the parathyroid gland will sense that there is no calcium in the blood. This will increase the calcium mobilization from the bone to the blood, producing hypercalcemia. The hypercalcemia, it has many symptoms, including mental activity and muscle activity. It also produces kidney stone and polyuria and polydipsia. How we manage that? Hyperparathyroidism is not a good side effect after long administration of lithium. In this case, if we are intending to give lithium for a long period of time, we should monitor the serum calcium levels, and we should monitor the parathyroid hormone regularly. If we reached the toxic levels and the symptoms are clear, we should stop treatment of lithium and we use an alternative mode stabilizers like lamotrigine, which we talked about last muhadara. Lamotrigine and the valproate. This is the side effect of lithium on the endocrine gland. It can produce hypothyroidism and it can produce hyperparathyroidism. And we have explained the mechanisms involved. Next side effect of lithium is their effect on the cardiovascular system. So, lithium on cardiovascular system, it can produce different types of arrhythmia. This arrhythmia, as we know, is disturbance in the rhythm of the heart. This arrhythmia can be a direct effect of lithium on the heart muscle, on the myocyte, and this is due to interference of lithium with the ion channels, cardiac ion channels. Cardiac ion channels are important for the excitability of the myocardium. Also, arrhythmia can result due to indirect effect of lithium on the heart muscle. And usually, this takes place due to disturbance in the electrolyte balance. The balance between sodium and potassium. Then, as we know, sodium and potassium is very important regulating rhythm of the heart. The arrhythmia induced by lithium can result from direct effect or indirect effect. This arrhythmia can be of different types, is by affecting the sinoatrial node, which is the pacemaker of the heart. The sinoatrial node, lithium can produce sinus bradycardia, and as well it can produce sinoatrial block. On the AV node, it can produce delay conduction, as you know, AV node, atrioventricular node, AV node, this conducts impulses from the atrium to the ventricle. Lithium can produce delayed conduction through the AV node. With delayed conduction can result in BR prolongation or QTC prolongation. This is BR prolongation. This is a very serious side effects, and as well it can produce QTC prolongation. Prolongation of the QTC waves. Okay. Also on the ventricles, it can produce ventricular tachycardia, which is usually very fatal in overdose. Ventricular tachycardia. Also, it can produce EC changes mimicking myocardial infarction. So, what we can do in this case? How we can avoid the cardiovascular effects of lithium? First, we have to monitor levels of lithium, blood levels, because usually these toxic effects of lithium on the cardiovascular system takes place at the toxic high levels. We should also monitor the ECG. We should continue monitoring the ECG, and also we should be monitoring more in sensitive individuals, in individuals suffering from arrhythmia. These are the side effects of lithium on the cardiovascular system. Lastly, on the reproductive system, it can produce teratogenic effect, which is known as Epstein anomaly. Epstein anomaly, which is usually a cardiac defect in the fetus, defect in the heart of the fetus. Because lithium, of course, it can cross the placenta and affect the heart development. Also, it will affect the gastrointestinal system, including nausea, vomiting, diarrhea. It can produce direct gastric irritation, and this will stimulate the CTZ, and this will induce vomiting and nausea. So as we have seen, lithium, it has a serious side effect, especially if the blood levels is high in the toxic range, and if it is given for a chronic period of time, if it is given for a long period of time. So what we should do in case of acute lithium toxicity if the person is taking an overdose of lithium? This is usually very dangerous and it should be attended very closely. Usually, typical causes of acute lithium toxicity, including an overdose, and a person is taking an overdose of lithium, or there is a dehydration, the patient is not taking enough water. في الحالة هذه lithium reabsorption will be high and lithium elimination through the kidney will be low, or drug interaction, as we have said, like NSAID and ACE inhibitors, or the person is suffering from impairment in the renal function. So what are the symptoms of acute lithium toxicity? The early symptoms include nausea, vomiting, and diarrhea. If the patient is suffering from nausea, vomiting, and diarrhea after treatment of lithium, he should immediately consult his physician. Other symptoms including neurological, اللي هو tremor. As we have said, there is a coarse tremor and fine tremor. If the patient is suffering from coarse tremor, this is an indication of acute lithium toxicity. Also, a confusion, ataxia, dysarthria, and seizures, which is the most dangerous. And severe acute toxicity can lead to coma, hyperflexia, and increased cardiac muscle tone and cardiac arrhythmia. And this is most dangerous because especially ventricular arrhythmia. How we manage acute lithium toxicity? Of course, first we have to stop lithium immediately. We have to stop treatment with lithium. Second, we give a patient a lot of fluids, hydration, and electrolyte correction. If needed, we do hemodialysis in cases where the levels are very high or symptoms are severe. The patient is exposed to hemodialysis to remove lithium if the levels are very high. In this case, to avoid acute lithium toxicity, we should regularly monitor blood levels of lithium, initially weekly at the beginning of therapy, and then every 3 months. We always measure blood levels after 12 hours after the last dose. These are the pharmacology of lithium. Lithium, we said, it is a monovalent cation. It is very effective in treatment of mania. It is the gold standard for treatment of mania. But It has specific pharmacokinetic where it is completely absorbed and completely eliminated through the kidney. Its elimination depends on the kidney function, which can be affected by different factors as we have explained. Lithium can induce acute toxicity and chronic toxicity. The acute toxicity usually dangerous and should be monitored very closely in intensive care unit, while the chronic toxicity needs direct attention from the physician and the patient himself. A second or last group of drugs which are used in treatment of mania and manic depression are the atypical antipsychotics. And we talked about the atypical antipsychotics when we talked about treatment of psychosis. And we talked about them last week when we used them in treatment of mania, acute mania, or maintenance therapy. فالtypical antipsychotics are used in acute mania, as we have explained before. Either this is used in case there is psychosis of the patient, agitation, or both. Why we use them? Because they produce fast action. Because they use fast action. So we use them in acute mania as single, or single means monotherapy, or adjuvants with other mood stabilizers. Second, they are used in mixed episodes or human mania and depression, they are proven to be more effective than lithium alone. In mixed episodes of manic depression, we usually, as we have said, if we use lithium alone, is not effective. Usually they found that by addition of atypical antipsychotics, usually they get a better response. Also, they are used where in places of lithium, when either lithium is not effective or not tolerated by the patient, or lithium is contraindicated, as in cases of pregnancy or renal impairment. Also, they are used as maintenance therapy in cases of mood stabilization in bipolar illness. So what are the treatment strategies? Treatment strategies of mania. What we use? Do we use monotherapy or combination therapy? This depends on the severity of the illness. If it is mild to moderate mania, monotherapy with lithium or antipsychotic might be enough. ولكن in cases of severe mania accompanied by psychosis, usually we use a combination of therapy of lithium plus antipsychotics. A treatment strategy, we should titrate and monitor treatment. If we use lithium, we should monitor serum levels of lithium. We should monitor renal with thyroid functions and ECG. As we have said, lithium, it has different side effects on the function of these important organs. If we use valproate, we should monitor liver function test and CBC, لأن الvalproate, as we have said before, it can produce rare thrombocytopenia and rare pancytopenia. Okay. Lastly, if we use antipsychotics, we should monitor metabolic syndrome, which is weight gain, hyperglycemia, with insulin resistance, with dyslipidemia, and also we should monitor the extrapyramidal side effects induced by these antipsychotics. By this, we have finished talking about treatment of mania, and in summary, we talked about the pharmacokinetic of lithium, how it behaves like sodium in the absorption and elimination. We have talked about the mechanisms involved in the antimanic effect of lithium, including its inhibition of the inositol monophosphatase and inhibition of glycogen synthase kinase. We talked about the side effects of lithium, including its effect on cardiovascular system, the endocrine system, and the GIT. We talked about the acute toxicity and its treatment, what we should use. We talked about the use of atypical antipsychotics in treatment and what are the treatment strategies. In the end, I would like to thank you very much for your attention. I hope to see you again in my next presentation, which will be about treatment of pain. I hope to see you in good health and prosperity. والسلام عليكم ورحمة الله وبركاته. شكرا لكم على حسن الاستماع. الرجاء لا تنسوا الاشتراك في القناة، الإعجاب، التعليق والمشاركة مع الزملاء. دمتم بخير وعافية، والسلام عليكم ورحمة الله.